Then this slide, ladies and gentlemen, talks about emergency treatment. We do have to perform quite a lot of emergency procedures on kids because they're always falling and breaking things, and yeah, it's just quite a lot. Né? So one, we're talking about fractured teeth. So this is a very common procedure that we find in dental practices, very important, with anterior teeth obviously being the most involved. Né? So should we have such a fracture or fractured teeth, as I had mentioned before, we will treat it in a similar fashion as we did with the emergency procedure that I had talked about earlier on. So such a child obviously has to be seen by the dentist as soon as possible after the accident, ideally within 30 minutes, because this then results in a greater survival rate for the tooth. Okay, and then from there, it's the dentist's responsibility to actually examine the tooth, take a history of the accident, perform vitality tests, as well as taking radiographs, most commonly being periapical radiographs, just to check what's happening in that particular area. Né? So then the treatment of this fractured tooth will then just depend on the nature of the injury, as well as with the vitality of the pulp of said fractured tooth. Okay, so at the initial appointment, the pulp is treated, like I said, either with a pulpotomy or pulpectomy, depending on the extent of the closure of the apex of the tooth, and then from there, making a temporary or placing a temporary restoration that is needed for protection. And then afterwards, the dentist will then wait about 3 to 6 months before continuing or taking further treatment on this fractured tooth. And then this is then essentially done to give the pulp a chance to recover without any additional injury. If the tooth recovers in 6 months, a temporary restoration is then placed. Sometimes, like I had mentioned before, it's most common in anterior teeth. Normally, if by the age of 6 or 7, these teeth would have just freshly erupted into the oral cavity. You guys must remember with the development of teeth that roots take about 3 years to actually completely close. Né? So I'm saying that to say that in terms of vitality and root canal therapy that we do on these teeth, you can't exactly, depending on how severe or badly damaged the tooth is, you might find that you cannot completely do an RCT at that particular stage because the root has not completely closed. So you'll have to stall up until the patient is like 9 or 10 years of age to actually then go about and actually do root canal therapy, like complete root canal therapy on that tooth, and actually place a permanent restoration. So now that patient is going to be with you guys for a prolonged period of time. From there, we have traumatic intrusion. So this is a situation where a tooth has basically been driven further into a socket. I'd make an example of, let's say your child was involved in a fight at school, and then they punched your child in an upward motion, causing that tooth to be driven further into that socket. So that tooth has basically undergone occlusion because it is not in the line of occlusion anymore. So this basically occurs when a tooth is forcibly driven into the alveolus so that the portion of the crown is visible. Né? So treatment for intrusion is to either allow the tooth to re-erupt on its own, or to see a dentist for repositioning of said tooth and splinting adjacent teeth to actually hold it into position. I have mentioned before that we actually splint children quite a lot, sometimes with orthodontic wire or by making use of composite restorative material if said practice does not have a splinting wires. Né? So traumatic intrusion of primary teeth may cause damage to the underlying development of or underlying developing permanent teeth, and the damage can result from physical trauma, such as in a fight, as I had mentioned as an example earlier on, or from infection of traumatized teeth. And this damage is then determined when the permanent teeth then erupts. So sometimes all you guys can do is literally wait it out, wait for the permanent teeth to then erupt. Sometimes it's either fractured or the crown of the tooth has a defect that we will then have to sort out once it's fully erupted into the oral cavity. We then have instances of displaced teeth. So lateral or extrusive development or displacement or luxation, which is when a tooth is moved from its original position of primary teeth should be repositioned by the dentist as soon as possible, especially if it's as a result of traumatic injury. So the roots of primary teeth, they go through the resorption faster after an injury and if the teeth are mobile. So if infection occurs, the teeth are then removed. So after the teeth are repositioned, they are held in place with a splint, normally 8 weeks all the way up to 6 months, depending on how the tooth and the underlying structures are cooperating. The splint is then left in place sometimes for 2 to 4 weeks in order to stabilize the teeth. Sometimes, or in most cases, this is usually longer, and just to try and actually get that tooth to be stable, we then encourage the parents to actually put the child on a soft diet so that we do not cause more trauma or increase the mobility of this tooth while we're trying to stabilize it. Okay, so often with these injuries, the periodontal ligaments are damaged quite extensively, and then the teeth will then have to be monitored for vitality, as with fractured teeth, as I'd mentioned earlier on, and then are assessed for endodontic treatment, particularly once the permanent teeth have erupted and we have root closure of that permanent tooth. Okay, and then from there, wholeheartedly, we have avulsed teeth. So these are teeth that are knocked out of the mouth. So the child fell, there was an accident, or whatever the case may be. So primary avulsed teeth, they are not replaced because of infection as well as ankylosis. So ankylosis, ladies and gentlemen, is basically when a tooth does not have a PDL space, a periodontal space, and then it just literally attaches to the underlying bone. So that is a problem because it may cause impaction of the underlying permanent teeth. Okay, so ankylosis, like I mentioned before, is the fusion of bone and the cementum of the tooth. In such instances, then, with primary teeth, we will not be replacing them. However, with permanent teeth that have been avulsed, they must be replaced as soon as humanly possible after injury. We instruct the parents to replant the tooth immediately. Like we had mentioned before, remove debris, grass, gravel, any debris, place with a damp cloth or in milk, and then come to the practice as quickly as possible. And then from there, if the tooth cannot be implanted, like we said, come to the office, and then caution must be taken with avulsed teeth to place it in carefully and to not rinse it off of the fluid, being the damp cloth or the milk that it was placed in. And then time, more than anything here, is a factor. Getting to the practice as soon as possible. That's why we always make sure that when a patient comes into the practice, they tell us what they're there for, because if it is an emergency procedure, it is very time sensitive to ensure the survival of that tooth. And then from there, we'll give the child post-op instructions, we'll give the parents some post-op instructions, place them on a soft diet, splint if necessary, and then we'll just do regular checkups every 3 to 6 months to check the status as well as the vitality of that tooth. Slides, ladies and gentlemen, just go on to explain what I've already explained. So with fractured anterior teeth, they'll visit the dentist, we take x-rays, we do some pulp tests, we treat the pulp. That is our main point of concern. Place temporary restoration if necessary, wait it out 3 to 6 months, and then place a permanent restoration if we are satisfied with the health of that pulp of that anterior tooth. This slide talks about traumatic intrusion. As it said, here's the infraocclusion. Like I said, the tooth will be below the line of occlusion. This tooth would then require endodontic treatment, and then we'll have to wait it out and see if the permanent tooth is damaged or not. Then from there, this slide talks about replacing an avulsed tooth. Now, this is a tooth that is all driven completely out of its socket, where our tooth has to be kept moist, either with a damp cloth or milk. Then from there, the site in the mouth is examined, we clean it off debris as well, and then from there we administer local anesthetic. X-rays are then taken, and then from there the blood clot is removed from the alveolus, because from the point of the injury or accident taking place to the dental practice, a blood clot would have obviously formed to then allow healing. We do not want healing at that particular time because we need to actually insert the tooth back into its anatomically correct position first. And then from there, the avulse tooth is then cleaned off in saline solution. You will have done this or have to do this at the practice. And then we insert the tooth back into the alveolus. So with avulse teeth, we have a very high success rate when it comes to our pediatric patients, but this is not necessarily the same in adults because the cells that we require to keep the tooth alive diminish with age. Okay, so replacing an avulse tooth will have to splint, like I said, either with orthodontic wire, or some dentists make use of composite resin material to actually retain the tooth into position. We will give the patient antibiotics, analgesics, as well as a chlorhexidine rinse to be prescribed and taken appropriately at home to reduce inflammation, to reduce pain, and to remove any form or sources of bacteria as a result of the injury. And then we'll have to assess the patient and check and evaluate if endodontic treatment may be required at a later stage. So that's essentially what happens with the different types of emergency procedures associated with our pediatric patients. Okay, and then ladies and gentlemen, we have to unfortunately discuss child abuse, okay, because child abuse is actually quite common. You see a lot of the signs, and it's actually the responsibility of everyone in the dental practice to evaluate our children that get into our pediatric practices for signs of child abuse. So forms of child abuse include and are not limited to physical child abuse. So we'll find bruises and marks that cannot be explained by the child, or sometimes you'll find that they're with an adult that is just quick to disregard or brush off some of the signs that we may see on the child. There are also signs of sexual abuse, signs of neglect, where the mother looks or the father looks absolutely stunning, but the child looks dilapidated, the clothes are worn out, the child looks disheveled, looks like they haven't eaten, stunted growth, bodily growth at that. And then as well, we find emotional abuse. So ladies and gentlemen, some of the signs that we will find of child abuse, very important in our dental practices, will include fractured teeth, fracture of jaw bones, which is very uncommon with children, with the exception being if, let's say, there was a car accident. Even with car accidents, ladies and gentlemen, because of the elasticity of the bone of children, we do not find that the jaws completely break, even in motor vehicle accidents. So jawbone fractures are really not that common with children, so it should be a red flag if you see that in the dental office. We have lacerations, especially around the labial frenulum. So let's say especially if like in instances of domestic violence where the child is being punched, you will find lacerations around the labial frenulum. We have missing teeth with no explanation. So when you ask the guardians or the parent, they cannot account for what happened to the teeth. They're very shady or very dismissive with their explanations. That should be a red flag for you guys. And then as well, bruises or scars on the lips should also be a red flag, especially if no one wants to account or the story is not coming together when it comes to this child. It seems like a very weird topic, but they're very common, ladies and gentlemen, so please just be aware. Sometimes you may actually even notice marks on the child's arms, legs, and neck that may be noticed by the dental team. There's a lack of personal hygiene or appropriate clothing for the season. So now, coming back to marks and scars, you'll find it's literally the middle of summer. Now you'll have a child, it's like 34 degrees, the child is like wearing a polo neck. That in and of itself should be red flags, because there's obviously something that is being hidden and may need to be addressed. And then from there, extensive caries, because the child is not brushing, they're not taking care of the child's oral hygiene. And then as well, a lack of response towards the need of the child to receive dental treatment, and the concerns of the dental team are actually being dismissed by whoever the child came with. You'll find sometimes you have kids who are so terrified of their guardians or their how can I say, the caretakers, that when the child, despite that everything is colorful and bright and everyone is friendly, they are really not being responsive. But as soon as this person leaves, then the child relaxes. That's also like a very big red flag, because kids are not supposed to be reacting in such fashion, or the child is petrified of this person. Sometimes another big red flag is when you find a caretaker or a guardian that refuses to be away from the child during dental treatment. That is also a big flag, because in most instances, they don't want the child actually saying something that could alert you guys to possible child abuse. So they make sure by all means that they are always as close to the child as humanly possible at all times. Even as far as if the child asks to go to the bathroom, they insist on being there, because sometimes as the assistant you'll be like, no, I'll accompany the child. No, they'll still insist on being there at all times. So it's all of those red flags. That's why it's so important to have the number of like the nearest police station where possible, have the number of a social worker at the practice, have the numbers of one or more guardians or next of kin, somebody that you can maybe talk to, and do not alert that person. If the abuser is there, obviously you do not want to alert them to you guys' suspicions, so you'll have to maybe, as you're treating the patient, have somebody else that's part of the dental team, maybe in another room, calling someone or an authority on the matter to actually come and assist or even talk to this child. You'd rather over exaggerate than have a child that's being abused that's too scared to say something. So please be on the lookout for those physical signs, as well as orofacial and dental signs that are common with such kids, so that we can get the appropriate help for them.